For more medical podcasts, visit us at podlearn.org.
Hi there, my name's Rick Phaeton, and this is my second podcast for the PodLearn team. I'm going to deliver 2 podcasts on inflammatory bowel disease. The first podcast will be today, and it is on Crohn's disease. So this is just a brief outline of what I'm going to speak to you about. I'm going to speak to you about why these diseases occur, how they manifest, how do we investigate, and what do we do to treat these diseases. So, what is Crohn's disease? It is a chronic inflammatory condition which can affect any part of the GI tract. It tends to favour the terminal ileum and proximal colon. It most commonly presents between 15 and 30 years of age. It affects slightly more women than men and is twice as common in smokers. Why does it occur then? So the etiology and pathogenesis is poorly understood. One theory cites that increased activity of type 1 T helper cells occurs. This increased activity stimulates the release of cytokines which drive an inflammatory process which affects the bowel, and this leads to the disease process. Another theory suggests that a genetic predisposition to the disease leads to complex changes in epithelial barrier integrity and homeostasis, which in turn leads to the inflammatory process which we see in Crohn's disease. So microscopically, what happens? Focal inflammatory infiltrate around crypt cells. There's ulceration of superficial mucosa, and this is essentially just a break in the normal continuity of the mucosal lining. Inflammatory cells are attracted to this area and they invade deep into the mucosal layers, and this leads to the formation of granulomas. These granulomas extend through the intestinal wall and into the mesentery. Neutrophil infiltration leads to destruction of crypt cells and atrophy of the colon. Macroscopically, we see hyperemia, which is just increased blood flow, and edema of the bowel wall. Superficial ulcers form over lymphoid aggregates, and these are seen as red spots or mucosal depressions. Ulcerations become deep, and they can extend transversely or longitudinally over the inflamed mucosa. And transmural, which essentially means through the full thickness of the bowel, this inflammation leads to bowel wall thickening and lumen narrowing. And if you can understand this disease process, you can then better understand some of the complications of Crohn's disease. So what are the clinical features? So I've broken these up into intestinal and extra-intestinal features. The main intestinal features are abdominal pain, diarrhea, PR bleeding, and perianal abscesses, fistulas, and skin tags. So I've now divided these symptoms into the area of the GI tract affected. In active small bowel disease, diarrhea is very common, alongside weight loss and anorexia. In large bowel disease, abdominal pain is prominent, alongside PR bleeding and PR mucus. In perianal disease, perianal pain is common, alongside perianal discharge. So what are the extra-intestinal features of Crohn's? In the eyes, one can get conjunctivitis, scleritis, episcleritis. you can get ulcers in the mouth and erythema nodosum, which are painful purple patches which tend to occur on the shins. You can also get large joint arthritis and osteomalacia, and fatty liver disease and renal stones are also common in Crohn's patients. So, how do we investigate? I've divided our investigations into 3 categories. Firstly, by the bedside. So, within any disease, history and examination are key. We can also send off a stool sample for microscopy and culture to rule out infective causes of abdominal pain and diarrhea. In addition to this, we can do blood tests looking at the FBC for any signs of anemia, and it's important to look at whether these patients are iron deficient. On the FBC, we can also look at the white cell count to give us an idea of whether there is any active infection going on. In addition to the FBC, we can do CRP and ESR, which will give us a marker of inflammation going on within the body. LFTs offer an idea of whether there is any hepatic impairment going on, and it will also give us an albumin, which is a good marker of active disease process, and in active Crohn's the albumin will tend to be low. We can also do a bone profile, as Crohn's patients tend to be deficient in calcium. In terms of imaging, a good starting point is a plain abdominal film. Moving on from this, endoscopy, including gastroscopy and colonoscopy, are crucial to diagnosis, as we can visualize the bowel well and also take biopsies for further analysis. Nowadays we can also do MRI scans, and the use of MRI is becoming more common in the investigation of inflammatory bowel disease, as it allows us to identify fistulae or strictures within the bowel. So what do we do to treat Crohn's? So lifestyle changes are important. As I said, smoking is a risk factor for Crohn's, and thus stopping smoking can reduce the number of flares patients have. Pharmacotherapy is also important alongside good nutritional management, and surgery can also be used. Just a bit about pharmacotherapy. The aim is to reduce symptoms, induce remission, and maintain improved quality of life. Steroids are commonly used to reduce inflammation within the bowel wall, and these can be given oral or IV depending on disease severity. If patients can't tolerate steroids, we can use aminosalicylates, which also help to reduce the inflammation within the bowel, and literature suggests that these work by mopping up free radicals. Immunosuppressants such as azathioprine and methotrexate can be added in patients who have more than 2 flares in 12 months or do not respond well to monotherapy. We can also use anti-TNF agents such as infliximab, and these are used in severe disease which has not responded to conventional treatments. It's important that quite in-depth discussions are had between family members and the team looking after the patient before starting infliximab, as it has very serious and severe side effects, and it should not be used for a prolonged period of time. Once remission is achieved, we can use immunosuppressants such as methotrexate to maintain remission. So a bit about nutrition. It's very important in the management of Crohn's disease. It facilitates bowel rest and healing, and research has shown that exclusive enteral diet is as effective as steroids in inducing remission. A short course of total parenteral nutrition, which is nutrition through the vein, can be used in severe disease when patients are significantly malnourished or unable to tolerate enteral feeding. Calcium supplementation is also very important to prevent osteoporosis, as Crohn's patients tend to have a high bone turnover due to increased cytokine activity, and they also tend to be deficient in calcium due to malabsorption or concurrent steroid use. So when is surgery used? It's important to note that it is not curative. Within 15 years of diagnosis, 70% of Crohn's patients will have had one surgical procedure. And surgery is indicated when medical therapy has not worked, or when there are significant disease complications, i.e. small bowel obstruction, perforation, or intra-abdominal abscess. The affected bowel tends to be resected, and temporary or permanent stomas are formed. These can be reversed at a later date. So just some conclusions. Crohn's disease is an inflammatory process which can affect any part of the GI tract. It has intestinal and extraintestinal features, and nutrition, pharmacotherapy and surgery are the mainstays of management. Thank you for listening, and I hope you enjoyed my second podcast. I will be bringing you another podcast on ulcerative colitis in the upcoming week. Thank you.